time at the end to answer a few questions for everybody. I'm Dusty. I'm the VP of Marketing at VitalWare, and I'll be introducing our presenter today. Before I do, appreciate everybody joining. Today's webinar is Billing for Telehealth Services during COVID-19, Public Health Emergency. We know everybody's super busy and their schedules are a little messed up today, and so we appreciate you joining us. Before we start though, here's a few housekeeping items to remind everybody. All attendees are on mute just to eliminate background noise, but we do encourage you to interact with us. Please do this through the Q&A panel if you have questions regarding the topic of today's webinar. If you do want to chat, just if you have troubles hearing or different things, you can put that in the chat panel, but otherwise please use the Q&A panel if you have a question regarding the topic. We will answer questions at the end, as mentioned, and the slides from today's presentation will be put up on the webinar page on our website, and we'll send an email out to attendees as a reminder where to find that after today's webinar. And if you are joining us live, you will also be awarded one AAPC CEU, and we will email that out after the webinar as well. Okay, so today's presenter is our very own Ardith Campbell, who is our Content Product Manager. So Ardith, I'm gonna hand it over to you.
All right, good morning or good afternoon, everyone, and welcome to the today's webinar. And just to kind of get things started off, we do have our basic disclaimer that although the information is current as of today, CMS might change things within the next hour. So we do try to keep you updated by sending out vital alerts and everything. So just to keep you on your toes, I guess. All right. And just to kind of go over some of the telemedicine services here. I've got some of them listed here. I wanted to show you though, those who can provide evaluation and management services, which is going to be your physicians, like your nurse practitioners, physician assistants, and your certified nurse midwives, and those that may not provide E&M services. So that's like your clinical psychologists, the social workers, your pharmacists, and because CMS is pretty strict on saying that the folks on the left-hand side can provide evaluation and management services. Everyone else can do an assessment, but they do make the distinctions, and sometimes that will make a difference in code selection. And for some of those services, now these services are e-visits through a patient portal, and they are not considered telehealth services, even though you're doing them on a computer. And so you don't have to go through some of the other mental gymnastics to do these, and we'll get into some of the mental gymnastics a little bit later. What I do want to point out is that the 98970 and the 7 through 72 were originally published in the CPT manual to state that it was an evaluation and management service. And so CMS said, well, no, the providers that are going to do that can't do an evaluation and management. So they came up with the G codes that were an assessment and management. And those G codes are now payable by Medicare on the facility claim, your UB04. They are assigned to the status indicator of A, which means they are paid by the physician fee schedule. And then we also have our virtual check-in services, and these can be provided by auxiliary staff. So whether that's your nurse, medical assistant, your pharmacist, or other provider, they can provide these services. And then we have telephone services. Now the 99441 through 443, those are the evaluation and management and have to be done by the physician or the nurse practitioner, the folks that were on the left-hand side. And then other telephone services are the 98966 through 68. Now, the little update on this one is that the 99441 through 443 are now designated as telehealth services, and can be done via telehealth. And you can't see my air quotes because we'll be getting into some different nuances a little bit later. Now, the 98966 through 68 can be done by your auxiliary staff or your ancillary staff, and they're not, those are not considered telehealth services, and so it can be, it does get kind of a little strange when you're trying to designate what is telehealth and what is not, as you'll see as we go through the slides. Now, I did want to put in a slide here about pharmacists, because the most recent interim final rule that came out at the end of April said that you know, the pharmacists, they are considered auxiliary staff. And so anyone that can be deemed as auxiliary staff, you know, it's very similar to other clinical staff or other clinicians, and they can bill incident to the physician or other qualified healthcare provider, as long as they're under the, you know, following that provider's plan of care and under the appropriate supervision level. And it also has to be within your state scope of practice laws. So be sure to check the scope of practice laws, because they are going to be different for each state. And so the pharmacist cannot submit the claim, but it can be submitted by the physician that they're, or NPP that they're working incidental to, or the hospital. So just depending on how your contracts are set, how you're set up as a provider. All right. So for professional telehealth services, I just wanted to go ahead and say, you know, that for your evaluation and management section, your E&M codes may be based on medical decision-making or time. In the first interim final rule that was published at the end of March, CMS said you could go ahead and use the time that was listed in the in the final rule, where they discussed the changes that are coming up for 2021. But in the more recent one that was published at the end of April, they said, you know, that was causing some confusion. So just use the code that's based, that's in the code description. And it can be all time that's on the date of the encounter. And you do not need to use the history or exam as part of the elements, and it does not need to be, you know, more than 50% of the time spent in counseling and coordination of care. You can count the entire visit time, but they are not changing any of the definitions of medical decision making. So it's still the straightforward low, high, medium, what have you. All right, so for claim submission on your for your professional claim, you use the place of service that would occur if there were no pandemic. So if you normally see that patient via telehealth, the traditional telehealth, go ahead and use the place of service too. That's not changing. Now, if you normally see the patient in your office, and you know, because of the pandemic, you're now visiting with them at home, you would still use that place of service where you would normally see the patient. So if it's office, use the office. If it's a nursing facility visit and you're doing it by your, you know, through the other means of communications, that's appropriate. Now, if the patient visit does result in the order for or the administration of a COVID-19 test, then you would use that CS modifier to waive the cost sharing. And then any other modifiers that are appropriate. So, well, I was going to say 25, but you wouldn't be doing a procedure, but you know, like 57, the decision for surgery, or anything else that might need to go on there. All right, now the facility telehealth, we get into a little bit of a stressful situation. So the regulations is that there is really no facility fee for telehealth services because the originating site is where the patient is located. So CMS has provided a workaround because they did not have the authority to go back and change the legislation that stated this. So I gave you a little picture of a Zen garden because take a deep breath, and we are going to go on a journey because it's all about some legislative gymnastics and wordplay. So when is telehealth not telehealth? The answer is when you make the patient's home to be your provider-based apartment. So if you've watched some of our, or listened to some of our other webinars, excuse me, CMS has stated that to kind of get around that legislation where the patient's home cannot be a designated originating site, what they've said is that you can seek an exception to relocate the patient's home as a provider-based apartment. So they're saying you can relocate to multiple locations, and that location can be the patient's home. All right, so the basis is that they want to keep you being paid at the OPPS rate using that PO modifier. So when you have an on-campus and an accepted off-campus provider-based apartment, you can seek that exception. All right, so the email should be sent to your regional office, your CMS regional office, within 120 days of starting the services with the following location. And as long as you are going to be kind of relocating back to your original location. All right, so I didn't want to spend a lot of time there because I'm sure you've heard it. Now, what gets tricky is when we start talking about then that originating site fee. So please, whatever you were thinking about the originating site fee, kind of throw it out the window. So CMS is saying that when the facility is merely supporting the telehealth visit, so that would be an instance where maybe the facility provides the equipment that that the visits are being made upon, or you have a telehealth provider or a vendor for the telehealth services, and you have to pay the subscription fees. You're also, paying for the telephone service as well, and you have really very minimal auxiliary staff involvement. That is when you would submit the telehealth originating site fee. But when you've made the patient's home a provider-based location, and you're doing the visit with audio video and you have your auxiliary staff involved in that service, that's when you can bill for the evaluation and management service, or your G0463. So when CMS has kind of given us the twist that audio video services that are provided between provider-based departments are considered face-to-face clinic visits. They are not telehealth, even though they are not, even though you're providing them like telehealth, they're not viewed as telehealth. So that's where the wordplay comes in, because CMS is stating when those audio video services that can include the patient's home are considered face-to-face clinic visits. So I'm hoping that's starting to help you understand when you can do that. So during one of the CMS office hours calls, and it was on last Thursday, May 7th, CMS said that yes, you can go ahead and append the modifier PN without submitting that information to the CMS regional office, and then you would just receive the lower rate paid at the physician fee schedule. I have not seen anything in writing as of yet. And if you have any questions, you may want to go ahead and reach out to your CMS regional office just to see how they would like to have you handle those. Because in the interim final rule, CMS stated they expected about 500 facilities to be sending information to the regional office. And I know that that's woefully inadequate. And there was nothing said about, is it you send one email with everything? Can you send everything in an Excel spreadsheet? None of that has been addressed, and I've not seen any guidance come out for those. So basically, any of the services that you are providing that would be appropriate for a clinic setting, you can provide to your patients. And that is going to include now your physical therapy, occupational therapy, just, anything that where the patient would have come in for a visit. Instead, you can provide it audio, video, making the patient's home a provider-based department, and you can then bill for your evaluation and management level. And so kind of the clarifying piece, though, is that the ancillary staff needs to be involved to be able to bill that evaluation and management level, where, just for that originating site fee, there's, very minimal ancillary staff involvement. It would be the provider just merely supporting the information, the visit. So I'm really hoping that kind of helps you out. So there are certain outpatient, the therapy, education, and training services that can be provided. So the supervision levels still apply. Most are general supervision, and that just means that you can get the supervising provider on the phone. Now they're still going to require an order and be within the scope of practice, and then the facility can bill for those just as if they were provided at the hospital or that provider-based department. So you're doing telehealth, but you're not really viewing it as, it's not being viewed as telehealth. So I don't know if they want to say put rose-colored glasses on, but it does state that so those are just kind of the mental gymnastics that you have to go through so that CMS will cover those services. And there are some services, and of course they're listed in the CMS's list of approved telehealth services that can be done audio only. So there are certain instances where, you know, maybe the patient does not have a smartphone or a tablet to be able to do a Zoom meeting or Skype, or that there's really poor internet service, or just for some reason you're not able to establish that audio video connection. Another situation is you start out audio video and the video drops. In those instances, then you can still bill that as if you were doing an audio video call. And CMS has designated those in the list of telehealth services, even though they don't consider them to be telehealth services, which is also confusing. And CMS has also stated that those are just suggestions at this point, and they will be possibly updating that, but don't feel that you have to be restricted to only those. So where it would be feasible to provide those services audio only, you can, but CMS would sure like you to start to try to do audio video. And so here are some examples of the outpatient therapy, counseling, and education. So just kind of broken those out for you. So for example, the diabetes self-management or medical nutrition therapy, you know, it would be possible for you to provide those services solely by telephone without the visual context. All right. And then also that can also work for outpatient therapy. So if you have a partial hospitalization program, those also can be furnished in this manner. So you can have the patient's home designated as a provider-based apartment. And can do some of those by audio, but preferably audio and video, but none of the other partial hospitalization requirements are being changed. And so just kind of also as a reminder, if you have services that are being provided by the home health personnel, you can have your home health personnel work in other areas, just don't overlap the services. Just kind of, you know, you get it counted once. And so just be careful though that if the patient is under a home health plan of care, that other hospital staff should not be providing services like your wound care or your drug administration services. All right, so here we've got some examples of the physician-based services that can be billed by telehealth, or the telehealth that's not really telehealth. And I did just go ahead and list these out here for you by section. All right, so for the claim submission for the facility, you can use condition code DR for disaster related, and that's really supposed to be used if everything on the claim is related to the disaster. It's not going to hurt. You won't. It's not going to hurt you if you use it or don't use it. Modifier CR for your catastrophe or disaster related, those are not needed on the telehealth claims, and that is used for both professional and facility billing. Modifier CS, cost sharing, CMS is taking the stance that it is only supposed to be applied to the evaluation and management service that resulted in the order or the administration of the COVID test. They have not issued any guidance, even though they've been promising it for several weeks now. So the Family First Corona, the FFCRA, the Families First Corona Relief Act, and the the CARES Act, Corona Aid Relief and Economic Support Act have kind of said that it's items or services. And so kind of the question is, well, do you now append that to, if somebody has an RSV test or, a flu test? What about chest x-rays? All of that is still up in the air and we don't know. All right, and then also on your claims, any other modifiers that are necessary, like your GN or your GO for your therapy modifiers, and then also the PO or the PN for your provider-based status on the clinics. If you're an on-campus facility, you do not need to use the PO, but anything that is off-campus would. So we're still waiting for some more information from CMS. And like one of the things that is still outstanding is the reimbursement rates for some of the lab tests. They have not published I think the most recent laboratory fee schedule was published early April, and they have not updated since then. During the office hours calls yesterday, someone asked about the pricing, and CMS said they are still discussing that information. And so it could be that a little while before they are publishing that information, which kind of stinks because, your MACs use that information to process claims. And so there's lots of holdups. All right. And so now for the telehealth services, so if you're providing true telehealth services and not clinic services, then there are some modifiers that are used on the professional claims. They are not needed on the facility claims, except for the modifier GT, which would be used by critical access hospitals only. All right, and so now we are at our list of references, and so I'm ready for some questions.
Thanks, Arna. That was great. Just a reminder to the group attending here today, if you are asking questions, please use the Q&A panel. If you have some questions in the chat panel, they most likely will not get answered because we do not get those after the webinar. And so please place your question in the Q&A and we'll make sure it gets answered. If not live, definitely on the follow-up. So with that said, I'm gonna start asking some questions. First one, how can we bill for facility telehealth genetic counseling?
Okay, well, that would be how you would bill for your auxiliary staff. So you can, make the patient's home a relocated provider-based apartment, and then you would be able to submit the genetics counselor's test on the UB, and so whatever services services you were providing and coding for before the pandemic, you would be able to bill for now. So if that's the G0463 or your 99211, what have you, that would be the answer.
Great. All right, next question. Will you clarify the correct use of Q3014 by the facility when the facility is considered to be provider-based? Example, HBOT MD does a televideo visit with a patient who is located at home and doctor is on site at the facility. The hospital staff scheduled and registered the patient for the visit, open the visit with check-in, and then turn it over to the MD. Does this qualify as Q3014?
Okay, so if there's minimal interaction by the hospital staff, then you would use the Q3014. So if it's just a basic check-in procedure, that would probably fall under the Q3014. But if you have the nurse calling earlier in the day or just prior to the visit and getting some information like some vital signs or chief complaint, that kind of information, and the nurse is actively involved in that case before turning it over to the physician, that would then qualify for the evaluation and management level.
Okay, great. Next question. If we're doing telehealth check-in with OBGYN patients, but it is an RN or NP, are they qualified for Q3014?
Yes, they would qualify for the Q3104, the originating site fee. But if the patient's home is made into that relocated provider-based apartment, then you're and based on your state scope of practice laws, in Washington State, the nurse practitioners are able to have their own, can be a Medicare billing provider. And so that would qualify them to use the E&M code.
Okay. Next question is, I want to verify that since the therapy services are paid under the MFPS fee schedule and hospital will be paid under MPFS when billing for PN, would there be any reason to apply for the PBD relocation application?
I would say probably not. You would just want to make sure that you're documenting somewhere that it's that you're seeing the patient in the hospital or in their home, because CMS does state that it's the provider's responsibility to keep track of that information. We've not seen any documentation yet come out, and so there's another office hours call tomorrow that I'll be attending just to make sure that the information that I've provided today is correct, and if anything changes, then I'll make sure that in our FAQ document that we send out that information's updated.
All right, thanks. Next question, do we need to put in a roster of patients' home addresses if we choose just to move to the lower reimbursement with modifier PN?
That would be your decision, but if you needed to have a list of when you would have seen those patients and their home under that, if you can run a report to get that information to provide it for anyone who may be auditing, that should be fine. But really there hasn't been any guidance provided yet about that.
Okay. About when billing telephone calls done, 99441 through 99443, do those require the 95 modifier? Also, if the telemed is done for a COVID phone assessment, would we use the E&M, say 99213 through 95 CS?
All right. Well, the telephone calls done by, this one is a tricky one because you have to determine, is the service telehealth or not telehealth? And CMS kind of muddied the waters with this one a little bit, because if the patient's home is made a provider-based department, it's not necessarily, it doesn't qualify as a telehealth service, because then it becomes a clinic visit service. And so the 95 modifier on the professional claim is kind of, it's out there. I sure hope they provide some better guidance on that one, because it's crazy. And gosh, was there a second part to that? Did I miss it? My caffeine has not met therapeutic levels yet.
The second part was, if a telemed is done for a COVID phone assessment, would they use the E&M?
Okay, yeah. And oddly enough, the sequencing of the modifier CS was discussed in yesterday's office hours call, and CMS has not provided any guidance to the payers. So the MACs don't know that if it's a pricing modifier or not, but CMS is going to talk to them and let them know that it really shouldn't matter which way you sequence those the modifier CS. And so whether it's the 95 first or the CS first, it doesn't matter. And if the patient's home is made a provider-based department, then the E&M level would not need to have the 95 modifier, because CMS does not see that as a telehealth service, because it's a service being provided from clinic to clinic.
Okay, thanks. And we are getting some questions still about, we will have the presentation slides in the FAQ doc. It will be put on the webinar page on our website. The specific webinar that you're attending today will be on that page within a few business days. So check back there. We will email you if you're attending, so we'll tell you where to find it, as well as that CEU credit. So just wanted to let everybody know. We also have, I'm trying to keep our FAQs up to date on our website as well under the resource section. So if you check there, you can find a whole bunch of FAQs related to telehealth, COVID, coding, as well as other topics. Just wanted to mention that really quick and do a few more questions here. Can hospital-based rehab bill audiovisual telehealth services? We are hearing conflicting information that it is only for independent rehab facilities.
Okay, well, that's a new one on me. I have not seen anything where it says it was only for independent rehab facilities. So there's no restriction on, so yes, the rehab can bill for those.
Okay, we're gonna stay with rehab for a second. Rehab therapy in the hospital outpatient department that uses telehealth video audio. Can we charge with a CPT for the service provided on UB? And if so, what modifiers, and is Q3014 an option?
All right, so for rehab therapy in the outpatient, so if you are providing the services to the patient in the patient's home, and you make the patient's home a relocated outpatient department, then those are services that that would be provided in the clinic setting. You would bill just like you would if there were no pandemic, and so you would bill like your 97110 like normal. So yes, those would go on the UB04. And if for the originating site fee, you would not need to use that if you are billing for the regular CPT codes, whether it's the evaluation and management level or the therapy visits.
Okay. A few people pointed out, I think we had a typo on slide 4 regarding the G
Oops.
codes.
Oh, I'm sorry.
There was a range, G2061 through, just to confirm, that is through G2063. That is now
Yeah.
reimbursable, correct?
Yes. Yes. Sorry.
And that will
Yes.
be updated when we send it out, so don't worry. But thank you for the people that pointed out to us.
Old eyes.
I missed it too. All right, next question. For NPP incident to claims, are they on UB04 or 1500?
That's going to depend on how the provider is set up. So if you are billing for, so if you would normally bill that on your UB, then it would go on your UB. And for those providers that bill the kind of the global services on the professional claim form, then you would use the 1500.
All right, great. I think we'll do about 2 more questions here, depending on the length. There has been an ongoing debate regarding the level of E&M that a pharmacist can perform incident to. Most documentation references a limitation to 99211. Is your presentation indicating that a higher level of E&M can be performed incident to by a pharmacist?
Okay, well, the 99211, when you're billing to Medicare, they have the G0463. That's the only E&M, that's the E&M level they accept. So if you're billing Medicare, then it would be the G0463. For other payers, then it would be limited to the 99211. But there are some of the other services that the pharmacist can provide, like the 98966 through the 98968 calls, telephone calls. And so those are an option as well.
All right, great. I think this will be the last question for today. Please explain relocation of PBD again and the difference between G0463 and Q3014.
Okay, so to kind of get around the patient's home not being an eligible place of service for the originating site for telehealth, kind of the mental gymnastics and kind of paperwork trail that needs to be made is making the patient's home a provider-based department. And you can do that by submitting the information to your CMS regional office, and you can submit, so it's the your Medicare provider number or the CCN, your address, the patient's address. It does not need to have their name, just their address, and then the date that you started. And there's no mention made of, there's no reason why it cannot be sent all in one email, but there's been no guidance. So you may want to reach out to your regional office to see how they would like to handle those. And so once you have made the patient's home a provider-based apartment, then that is now viewed as a clinic, part of your hospital. And so when you provide services, those they're not telehealth services, they become clinic services. And so if your physician is, or your provider is then providing services to the patient in the kind of clinic, depending on the amount of involvement of auxiliary staff, then that would determine whether you can bill the Q3014 for the originating site fee, or if you bill for the other services like the G0463 for the facility site.
All right. Thank you, Ardith. There are a lot of questions out there still, so this is a popular topic with a lot of questions obviously floating around. We do try to answer all the questions in the follow-up documentation, but please give us some patience. There is a number of unanswered questions, so there's a lot of work to do for our team. But we will place that on the webinar page. Again, we'll email out the notification to you as well when that is up through email. But please check our FAQ pages under the resources section of our website. We just added about 20 or so questions and answers around telehealth the other day, and so there might be some answers out there ready for you. Otherwise, you can also follow us on LinkedIn. We try to update the industry there quite frequently, and so follow the VitaWare page on LinkedIn. If you're not on LinkedIn, that is where we do a lot of updates. We're also starting an email newsletter to hopefully keep you guys up to date a little bit more as well. And so if you check out the footer of our website, there is a short form to put your information in, and we'll make sure you're on an email newsletter distribution list. We'll be updating future webinars, past articles and topics as well. And so hopefully we're putting a lot of resources out there for you, and we'll do more webinars in the future as well, obviously. But thanks for everybody for attending. We'll send an email out with all the appropriate information in the next few business days, and hopefully you got some of your questions answered. Have a great week.
Thanks, everyone.